good morning, good afternoon, good evening, depending upon which part of the world you are in. My name is Vish Vishwanath. I'm the director of the Harvard India Chan Research Center. I'm also a professor of health communication at the Harvard T.H. Chan School of Public Health. I, on behalf of the school and my team, want to welcome everybody to this continuing series of webinars that the school's center has been holding in India. The Harvard Chan Center has been founded roughly a little more than 5 years ago with a specific goal of promoting collaborations in research and public health between Harvard Chan and institutions in India, building capacity and training and programs and workshops, for Indian public health professionals, and also translation and communications. How do we get the evidence base that is being compiled into the public arena? And this series of webinars that we have been organizing, we have organized more than a dozen of them, is intended to inform the public or publics on the latest developments around COVID-19. The situation in COVID-19 is very interesting. We are at a very critical inflection point. In fact, it's a cliche that people observe these days, the idea of an inflection point. But the fact of the matter is that we are in the third year of the pandemic. There have been more than 400 million cases all over the world, about more than 40 million in India, a little less than 6 million deaths. There has been untold suffering, social isolation, where people have not been able to meet, identify and mark milestones and markers in one's life, a generation of students without going to school, learning or not learning how to associate, how to socialize with classmates and friends, and of course, a plethora of mental health issues that are now beginning to be documented in things. At the same time, we have made tremendous progress. If you think about it, 2 years ago, we did not know anything about COVID-19, but thanks to the contributions of a large number of scientists from basic sciences, clinical sciences, or social and population sciences, we know a lot more today than has ever been the case. In fact, it is very impressive that the scientific infrastructure that we have been investing in the world over the last few decades has actually paid off. And thankfully, the scientific work or the foundation has also led to both treatment and vaccines. And that is, again, unheard of. And we have to sit back and reflect on it and appreciate that development. But we are also ready to move on. The question that keeps coming up right now is, how do we land the plane, so to speak? How do we move to a life that involves living with the virus in the short term, if not in the long term? How do we resolve the fatigue being felt by the people? Recent polls have been showing that 50 to 70% say they want to get back to normal, whatever that means. Support for masks and vaccine mandates is slowly falling. And there is a disjunction, which is very interesting, between their worry, what people are worried about it, yet at the same time, they're unwilling to support the mandates. So these are questions that keep coming up. And the question is, what do we do next? How do we get where we want to go? I couldn't be more happy and more proud to have 3 top-notch scientists with international renown who are going to join us and answer some of these questions for us. We have Dr. Gagandeep Kang. A number of you are familiar with her and her work. She's a professor of microbiology of the Christian Medical College in Vellore. She has made seminal contributions to infectious diseases in India and vaccination. We also have my colleague and friend, Dr. William Hanich, an epidemiologist who co-directs a center here and who has been very active, both scientifically and public communications. who will walk us through some of these issues. And we're also delighted to have Dr. Pramesh, a clinician who has also been very active, who's joining us, and who will answer some of these questions. Not only these three scientists have made seminal, significant contributions in basic sciences, clinical sciences, and population sciences, but they have taken their role as a scientist to educate the public very seriously. If you're following them on Twitter or other social media, you know how thoughtful and careful they have been and how conscientious they have been in leading us through this thicket of information. And this will be moderated by Ms. Divya Rajagopal of Economic Times and formerly of Economic Times. A number of you also should be familiar with Divya, who has been writing possibly one of the most eloquent, and she has been most articulate in her stories, identifying issues. Divya is one person I follow whenever I want to read in the newspapers about how things are shaping up. We are delighted Divya has been with us moderating these panels for more than 2 years, or almost 2 years. And we are so grateful that you can join us again, Divya. So please take it away. I want to thank everyone for joining us. And I also want to thank my team. We usually run out of time at the end, but I want to thank my team who have worked extremely hard in organizing these webinars, including today's. Thank you so much. Divya.
Thank you so much, Professor Vishwanath. And you're absolutely right. I think we started this seminar 2 years ago, and it's been 2 years, and so much has changed since then. So before I start off with the micro level questions with my panelists, I want to start with this really a big picture question about what does it mean to say that we are kind of transitioning from a pandemic to an endemic stage. Recently, Denmark has announced that they will treat COVID-19 as a socially accepted disease. Britain has also said that it will loosen all its restrictions. I want to ask, and this is a question for all the panelists, that is there a universally accepted measure of declaring that the pandemic has reached an endemic stage? We'll start with you, Dr. William. What's your view on this?
I've been asked that question a lot over the last few weeks. I want to point out that you should not mistake the fact that the word endemic contains the 3 letters END as necessarily meaning it is an end. I can think of at least 3 definitions of endemic. The most theoretical one is that it's the point where after a simple model of disease, the amount of infections decline to the point where they become stable and the rate of infection is determined by the resupply of susceptibles. But that doesn't mean that it's particularly mild. It doesn't mean that those infections are easily dealt with, and it doesn't mean that those infections are particularly few in number. TB is endemic in a lot of the world. Malaria is endemic in a lot of the world. Until a new vaccine campaign a few decades ago, polio was endemic in parts of India. So it's not necessarily a sign that it's something that we can ignore. However, there is a kind of popular definition which has been going around recently, which is that it's the amount of disease that people are willing to handle, that people are willing to tolerate within their communities. Because the only way the pandemic would end otherwise would be if we eradicated the virus. And I think we can all understand that with something like Omicron, and not to mention the fact that we know that it is now infecting wild animals as well, that's something which is really, really unlikely to happen.
Right. Dr. Kang, what's your view of how do we define an endemic state? Again, from the perspective of Indian context, what would you say that?
I couldn't agree more. I've worked on pretty much endemic infectious diseases through my professional career. And it's not like an endemic means that there is no disease, that it does not cause hospitalizations and deaths, nor does it mean that we will never see an increase in this disease ever again. A lot of endemic diseases fall into seasonal patterns, for example. So I think the definition that this is something where we accept that we are going to live with the virus makes a lot of sense. And we have to remember that living with the virus doesn't mean that we don't have to be prepared for increases in cases and in hospitalizations, or that we need to limit surveillance in any way, including genomic surveillance.
Right. Dr. Pramesh?
I think I agree completely with what's been said so far. Very often we find this uh, explanation that now that it's become endemic, we can relax and go on with life. And that's a fairly dangerous approach to take. And just as Bill and Dr. Kang just mentioned, we need to ensure that our level of preparedness is constant. And I'm sure we'll come to this later on in our discussion, but healthcare systems need to be on alert and ensure that we are prepared to deal with whatever variant is thrown at us. So now we've got the Omicron, which is certainly less severe than the Delta variant, but you never know what's going to come next. And unless we are prepared to handle whatever it has to come at us, we'll be pretty much in the same state that we were in early last year. So I think preparedness is key, and having a little bit of redundancy in health systems is extremely important, because I think the Delta variant exposed our health systems frailties extremely badly, and we shouldn't be in that same state again.
Right. Dr. Pramesh, you can unmute yourself. It's fine. Just to take it from what you said right now, that we cannot be treating this whole business as usual thing, and this is exactly where perhaps the whole conflict comes in, because when you look at again countries in the West, they're saying that we exactly want to go back to that business as usual state. Again, coming back to the Denmark example, the cases have been going through the roof, but yet the nightclubs have opened up because the country seems to have said that, okay, we have reached a record vaccination numbers, our health system is in place, and we have also ensured that whoever needs testing will get it. So again, to define that, everybody wants to sort of understand that when is that normalcy that we would get back to, and is that ever going to be possible? So just to kind of for the argument's sake, what would be that normal state we would ever reach to, and is it ever possible post the pandemic? Dr. Kang, I see you like smiling, and there's a lot going in your head, so please, what do you think about it?
So actually, I was thinking after our first round of questions, and I will come back to life as normal in a little while. But I was thinking one of the reasons that this pandemic, in India, we live with infectious diseases all the time, all kinds of infectious diseases all the time. And we tend to ignore them. You might remember that before the pandemic, we were doing this kind of non-communicable diseases are taking over the world. We don't need to focus on communicable diseases. India has undergone epidemiological transition. All of this was being discussed. Cancer and cardiovascular disease were more important than any infectious disease. And that's for you, Pramesh. But I think the reason that SARS-CoV-2 was so much in the news as compared to other infectious diseases in many ways was because this was one where all of society was susceptible. And what happens with most other infectious diseases that we deal with in India, tuberculosis is an example, Kala-Azar is another example, diseases that have been with us for a really long time, is that we don't see them highlighted among the rich. We don't see them in mostly urban areas. These tend to be diseases that it's very easy to take off the front page of the newspaper, which it wasn't possible to do for SARS-CoV-2. Now, if we go back to life as normal, does life as normal mean that we continue to ignore tuberculosis and all the other neglected tropical diseases that we have to deal with, and only focus our attention on what are called, the bug that I work on, rotavirus? We used to refer to rotavirus as being very democratic because it affects both, and it affects every country in the world. And if we look at SARS-CoV-2, maybe we define this as another reasonably democratic virus until there began to be the kinds of interventions that some countries could implement while others could not. And that is still the situation that we are in today, that there is inequity in vaccines. So the Denmarks of the world that have very, very high levels of immunization can think about what they consider as an acceptable level of hospitalizations and deaths and say we are willing to take that risk and move forward. Whereas other countries don't necessarily have the luxury of being able to do that yet. Will we get there? I certainly hope we will. But I think the important thing for governments and for populations to understand is that there is never a situation where there's no risk from this virus. So opening up and getting back to normal means incorporating and understanding that there will continue to be variable levels of risk, and could change that equation at any time.
Right. Thank you so much for that. Dr. Will, again, United States is one example where there is so much of contention about when do we know that the pandemic is over, how should we treat it, and with the new administration, there's this tension that's kind of building up on when should US say that, okay, we are out of the woods, and with the cases going really up. With the emergence of Omicron and also the subvariant that's come in, where do you see we are heading? What's your view on sort of reaching to that normal stage?
Well, let me start by applauding the previous answer. I could not agree more with everything that was said. The United States is a very divided country. That's not news to anybody. And I think part of the difficulty that folks have talking about it is that as we speak, there are still pretty high levels of mortality. We're losing about 2,000 people or more every day. We lost 15,000 people in like the last week, which is half a flu season. So there's still a substantial amount of infection and death going on. And we've only managed to emerge from the hospitalization crisis quite recently in some places. However, that is really driven by serious infections among the unvaccinated. A relatively large fraction of the United States is unvaccinated. Even within places like where I live in Massachusetts, where we have a substantial fraction of older folks vaccinated, and not only vaccinated, but vaccinated and boosted, it's still worse than those European countries that are saying that they are opening things up and so on. And the difficult thing to remember is that when European countries say they are removing restrictions, those are restrictions that were removed in much of the United States quite a long time ago. And that's one of the reasons we are still in this situation. So what I think is going to happen over the next few months is that, variants allowing, we are going to see an expected subsiding in terms of numbers of infection. The hospitalizations will take a little more time to dampen down because of the fact that it takes a little while for the virus to get into vulnerable older populations. But then after that, I suspect there's going to be a recalibration and people will be trying to declare that as normal. Now, the caution I want to put on that is that the great foe that we've been dealing with has not so much been the virus as our own inflexibility in figuring out how to deal with it. And we need to be flexible. We need to understand that if something changes, we need to change, because we have seen the consequences too many times over the last 2 years of failing to do so.
Right. Dr. Naresh, I want to come to you about, there is so much now that we know about COVID that we didn't know 2 years ago, especially from the perspective of, how it's impacting patients with other diseases. In your experience, in the last 2 years, how has COVID and COVID's impact has been on cancer patients, for example? Has there been any study or any sort of breakthrough that you're seeing which you think needs to be explored further?
So I'll break this down into a couple of points. The first being the way cancer patients with cancer have dealt with COVID, and the second being the impact of COVID on overall cancer care. So the first bit is that we have a strong body of evidence which shows that patients with cancer do a lot worse than those without cancer, adjusted for all other comorbidities when it comes to outcomes of COVID. So it ranges anywhere from a 5 to 8 fold difference in mortality. So we're not talking small numbers here. So if the overall mortality in India with COVID has been in the range of, the case fatality rate has been in the range of 1.2 to 1.5%, the mortality rates in patients with cancer has been in the range of 10 to 11%. And 10 to 11% in India is at the lower end of the spectrum of what patients with cancer globally have had as a mortality with COVID overall. And here I'm combining predominantly the alpha and the delta. We don't have data on the Omicron yet, but nevertheless, that's very illustrative of the fact that we've had anywhere from a 5 to 8 fold higher mortality with COVID in patients with cancer than those without. Several theories for that: the immunosuppression because of the disease, the concurrent comorbidities that a lot of patients with cancer have. So you could go into the theories of what causes this, but nevertheless, it's a hard fact that patients with cancer do much worse than those without. The more important, and probably I'm looking at this from a purely public health point of view, is the impact that cancer care has had as a consequence of COVID. And again, I'd like to break this into two aspects. The first being the restrictions which have led to access to prompt cancer care being hugely compromised as a result of the pandemic. And the second being the fact that because of the COVID overwhelming the healthcare systems, the access has been even further reduced. So the first bit about restrictions have been pretty harsh. So if you look at most major cancer centers in the country, in India, we've had anywhere from a 30 to a 70% reduction in volumes of patients registering for cancer care in most of the large cancer centers. We recently published in the Lancet about the impact of COVID on cancer care volumes in the first wave. And we are now likely to share our experiences with how badly patients with cancer have fared as compared to those without cancer. And the numbers aren't happy. It's huge differences that we are seeing here. And both of these are leading to excess mortality, both with COVID as well as with cancer. And this is something that we need to really address. And to all those who say that Omicron is mild and it's not overwhelming healthcare systems, I'd like to just point out that every bed that you have, which is occupied by someone with Omicron, is taking away a bed of a potentially curable patient with cancer who goes on to develop more advanced disease.
Right. No, thank you so much. I think there is the impact of COVID on other diseases has been a different kind of an silent issue altogether, which has not been explored yet. But we hope that there's more research coming up on that front. Coming back to Omicron and vaccines, again, there is this 2 years down the line. Most countries, especially in the West, have reached 70% vaccination numbers. But now there is this whole debate about boosters. Should there be boosters, and are boosters even working with the Omicron variant or not? How should a public policy person sort of convince people to take boosters and sort of say that there is still some merit that's there? What's your view, Dr. Will? How's the conversation going on in the United States again about boosters, and how do we convince people that it has benefits?
Well, I think the first thing to comment is that vaccination is helpful against Omicron. That's a very simple message I'd like to get across. While a lot of people refer to Omicron as an escape variant, it is the closest we've seen to one that fulfills that description. It's not a complete escape variant. It is able to infect people who have been vaccinated or previously infected, but it causes less severe disease in them. And that's really important because, as we were just hearing, you want to keep people out of the hospital because we want hospitals to do so many other things. So a vaccination which will not prevent infection but will prevent severe disease is still really helpful, and the vaccines are capable of doing that. Now, you can also take a booster, which is a third dose, and that has been shown to reduce further the risks of severe disease and, for a period, infection. which is obviously an extremely helpful thing, but it is particularly helpful for those who are most at risk of severe disease. I'm talking here about folks with comorbidities. I'm talking here about older people. And that's an extremely important issue. Still here in the US, too many people over the age of 65 have not received boosters. And I think the thing which people don't realize is that when you say that 90% of the over 65s in the United Kingdom have been vaccinated, and we're nearly as good at that, nearly as good with 70%. No, 70% is not nearly as good as 90%. It's 3 times worse, because rather than 10% left vulnerable, you have 30% left vulnerable. And that's something which folks really don't understand. There's another issue on top of this, though, which is the vaccine equity. For a lot of people, especially those under the age of 65, it would be the additional benefit of a booster is comparatively small. And there's a real issue. It would be a much better use of the resources we have if those third doses going into people who are in their 30s were instead first doses going into people elsewhere in the world who are yet to receive any vaccine. And that's unfortunately a problem that public health cannot solve. It's something which requires political will. And I would love to see more efforts going into that.
Right. Dr. Gagandeep, I know that, we've had several discussions on boosters, especially from the Indian context. Should we open it up for everybody? Because right now it's still restricted to a certain number of people. Looking at Omicron and the emergence of new variants that we don't even know now, the names, but what's your view on boosters in India?
It's complicated. So let's start with, yes, absolutely, people who are older and who have comorbidities should receive boosters. But my question really is, when you get beyond that, in India, what we've tended to do is treat all the people that are eligible for vaccination as one category, and we measure the numbers as a whole. We are not age stratifying our coverage data in the way that it should be stratified. I'd be really happy if we had 95% coverage of the over 60s and people with comorbidities with 2 doses, and then you can give them boosters again. I'm less concerned about boosters going into younger people, but what seems to be happening is, at least in India, the policy is to give it to healthcare workers. I'm not even sure that healthcare workers in India really young, who are employed at the moment, who are younger populations, really need to get the booster dose ahead of somebody who is over 60 years of age. I also agree that we should be looking at doses being given to people outside of the country as much as possible, because 2 doses given to everyone in the world is much better than 3 doses given to some parts of the world. The other thing that I think we need to think about is, which vaccines should you boost with, or should you be thinking about combinations of vaccines? Much of the data that we have on how well vaccines are working really comes from 2 kinds of vaccines, the mRNA vaccines and the viral vectored vaccines. We don't have data on any others. In India, we have only the viral vectored and the inactivated vaccines that have been given to the bulk of our population. Should we give them a 3rd dose of the same vaccine as we are doing now, or should we be considering other vaccines as better boosters than homologous series? Well, we don't have the data to inform that, and I think we should be doing our best to generate it.
Right. Dr. Pramesh, do you see within Tata Cancer Hospital, the boosters for especially cancer patients has picked up? What's your view?
Let me start by saying I can't agree more with what Dr. Kang and Bill said just now. 2 very important points that they spoke about was about triaging the available vaccines to the ones who needed it the most, And the second point about going beyond borders to ensure that vaccine inequity is a thing of the past. You might accuse me of being a communist or living in a utopian world, but I strongly believe that in most situations, in more than 90% of situations, vaccinating the rest of the world is more important than giving a booster to people. And I think Dr. Kang mentioned exactly the subpopulation who would benefit the most from the boosters. So a healthy 62-year-old will benefit less from a booster than a 15-year-old with acute leukemia who was on therapy for cancer, right? So it's these kind of distinctions that we need to make if we were to ensure that the precious doses of vaccines that we have are used wisely. And if you look at the overall vaccine map of the world, I think it's shameful from a public health perspective. You have countries which have vaccinated kids, which have vaccinated the adult population thrice, and you have other parts of the world. I'll take sub-Saharan Africa as an example, where we haven't even reached a double-figure percentage as far as coverage of the population goes. We've not even vaccinated the elderly. We've not vaccinated the ones with comorbidities. We've not even vaccinated healthcare workers in Africa, for God's sake. So I think this inequity is something that we really, really need to look at. And rather than have these arbitrary age distinctions as anyone above the age of whatever, 50, 60, or whatever it might be, will benefit more from a booster than others, we need to look at the overall picture of comorbidities like cancer, like immunomodulatory diseases, where the consequences of getting serious COVID is far more than the average person getting a booster in the world. So.
Right. So just to kind of follow up on that, do you see that sort of this rigid criteria in India for boosters is sort of hampering, for example, immunocompromised patients like the cancer patients are not getting their boosters, which they should be getting? Are you seeing, is it sort of restricting you as a healthcare official too?
It is. So a 59-year-old today who has advanced cancer or any kind of disease which makes them vulnerable to severe COVID cannot get the booster today. Whereas a healthy 61-year-old with no comorbidities is eligible to get the booster. So I think we need to go beyond just age as a criteria and get in other factors which make them vulnerable to getting severe COVID. So here we are not trying to limit the number of people. So one of the problems that the pro-vaccine group has suffered from is the fact that we've been evangelistic about promoting vaccines to the point of not evaluating the evidence adequately. So we have some evidence to show that vaccines do reduce transmission, but the strongest evidence is towards vaccines reducing severe disease. And by trying to promote vaccines as the panacea to end the pandemic, we've lost credibility because a fair number of people who've been boosted have got COVID. And the standard response that you get when you promote vaccines is the fact that, my neighbor had 3 doses of the vaccine and still got COVID, so why should I take it? So we need to be careful about how we communicate the findings that we know are true.
Right. I hope there are, government officials who are listening these insights that you're giving, and especially about the rigid age criteria from the Indian context and how it's not, helping people who really need the boosters. Again, staying on vaccination and vaccination for children, we see that Pfizer will soon be applying for the approval of 1 to 5-year-old vaccination. Sweden has said that they don't think that children should be vaccinated against COVID-19, and there is the rest of the world who are still trying to grapple with where they should be heading towards. I know there are interesting sort of discussion that will come out of here, especially with Dr. Kang and Dr. William. So I'll first get to you, Dr. William. What's your view on, of course, most of the West have started vaccinating children over the age of 5, but under that, what's your view?
It's a very complicated issue. I mean, the first thing to say is that infection in that age group is much less likely to lead to severe disease. But the risk is not nil. And there are some kids who are more vulnerable than others. And indeed, they have the potential, if they're infected, to transmit to other folks who are perhaps more vulnerable. I think that part of this, and by the way, the previous answer I thought was absolutely spot on when it comes to the way that we talk about vaccines, is one of the lasting pieces of damage that has been done by a misunderstanding about the nature of herd immunity that dates back to the very earlier stages of the pandemic. You have indirect benefits of vaccination in terms of preventing transmission, and direct benefits, which are in terms of preventing severe disease and potentially infection, but it's mostly severe disease. The risks of severe disease in children are low. If vaccines are available for them and are safe and protective, then that is something which we can certainly use because we do not want even small numbers of children to become ill and or die. And if there are things that will effectively produce that outcome, then that's something to be applauded and it should be deployed. But those vaccines are not going to be as helpful. You're not going to get as much bang for your buck vaccinating under fives as you will vaccinating some of the vulnerable folks that we were just hearing about. And there's an additional point which we have to think about in some countries as well. In some places, I'm thinking of the UK in particular, very, very large numbers of children have already been infected through what appears to be a almost deliberate opening of schools with very little mitigation. I think it was a couple of weeks ago, the Office of National Statistics there estimated that 12% of some age groups were infected. And within those age groups, you'll have some protection from prior infection, but also vaccines may provide less marginal benefit than you would if you were getting into a completely naive individual. So like I said, it's an extraordinarily complicated questions, but these are some of the things that go into thinking about it.
Dr. Kang, your view? Should we look at vaccinating children?
I'll add to the complexity. What if you have only one vaccine available and you're not sure it's the best one to use in children for the broadest and longest lasting protection? With inactivated vaccines, you can make the argument that it might give us broader protection, but you can't make the argument for longer duration protection at the moment, right? So I'd be very careful about going into children with a vaccine that has that characteristic. And the other thing I will think about is that in low and middle income countries, there are always trade-offs. Do I want a vaccine for COVID-19 or do I actually want to give children a pneumococcal vaccine, which Indian children do not yet get? I would choose the pneumococcal.
As a person who spent a lot of time working on pneumococci, I thoroughly understand where you're coming from.
Right. Can you sort of like expand a bit more on that, ma'am? When you say what's the trade-off that we should make?
Yeah, I mean the rest, when you think about vaccinating children, you have to prioritize the diseases that cause the most and sometimes long damage in children. And if you have something that has a predilection for children, which is you see most pneumococcal disease in children and in the elderly. So if you had to choose, rank order vaccines that needed to be introduced, SARS-CoV-2 would not currently be on my list. I would want to get into the Indian program, which fortunately now India has committed to, but hasn't completed the rollout for. Pneumococcal vaccine, HPV vaccine. There are a lot of things for us to think about before we get to SARS-CoV-2 in terms of mitigating mortality and morbidity in children.
Right. I think that's a very important, again, takeaway from what we've been discussing on vaccines. This is, again, staying with vaccines, this is again one of my favorite topics, is that the whole gambit of discovery of new vaccines and the work that's going on universal vaccine, perhaps, and all coronavirus variant vaccine that people have been talking about. That's one thing. And the second thing is the human challenge study, which UK recently completed. To begin with, the pan variant vaccine that everybody is talking about. How feasible is it? Dr. Kang, I know that you've been sort of advising CEPI on this. You also kind of have spoken about this in the past. Is this something that's feasible? Do you think we can get this perhaps in a year's time?
Well, did we think that vaccines for SARS-CoV-2 were feasible in 10 months? We sort of, made the right noises, but deep down, I don't think anyone believed that less than a year was feasible. But we were able to do it with the science, with the regulators, with the policymakers, with the resources, all being aligned. It became feasible to deliver on vaccines using a new technology that hadn't been approved for vaccines before. So do I think that broadly protective vaccines are feasible? Well, there are different ways of thinking about broad protection. You can think about just the beta coronaviruses. You can think about all coronaviruses. It's more likely that we'll get a vaccine that protects us against first SARS-CoV-2 and probably SARS-related viruses first, and then we can think about what able to give us broader protection against coronaviruses. It's feasible, but as with every other vaccine, it is going to be actual clinical data that show us that there is protection. And the problem is sometimes you need to have the disease to be able to measure that clinical protection. And, if one of the reasons that we didn't have a SARS vaccine was because there was no SARS to test the vaccine candidates that had been developed. Now, can challenge studies be a way to get around that? I think people underestimate the difficulty of challenge studies, as is obvious with what has happened in the UK. When you have to make a challenge virus, the characterization of the virus so that it can safely go into humans requires a very long process. So the challenge virus that we are using now isn't relevant to the situation that we have with SARS-CoV-2 today because it's based on an older version. There is a Delta challenge pool being prepared, but that's also going to take a while to set up and to do. So challenge studies have their, but what would be really helpful is very, very good animal models, which we don't have, and a correlate of protection, which we don't yet have either.
Right. We have a couple of minutes before we get on to the Q&A, but Dr. William, Dr. Ramesh, do you want to kind of share your insights on it? We'll start with you, Dr. William.
I think I completely agree. I wish that we had better correlates of protection right now. We have, unfortunately, a subset of the press has become obsessed with neutralizing antibodies and cross-protection from them, which are an important and valuable piece of data, but they're only a part of it. And I think that we want to also consider the potential immunity that comes from T cells and all sorts of things like that. So yeah, I would love to see a very broad coronavirus vaccine. And I think that it is not impossible, as we just heard. Whether or not it becomes available is something that we scientists are going to have to keep working on.
Right. Dr. Pramesh?
So I agree with both Dr. Kang and Bill when they say that it's ideal to have a pan-COVID vaccine. I mean, that's what's gift to ending this pandemic, right? But to me, even if that were to happen, unless we democratize availability of the vaccine across the world, I don't think that's going to really impact things much. And though there's a lot to be happy about over the way vaccines have developed over the last couple of years, I think there's equally as much to be ashamed of as a medical community. We've had over 5.5 million deaths, and we still have companies who have developed vaccines through funding from public money, refusing to share patents when it comes to enabling other organizations, other companies to actually be able to manufacture these vaccines at a lower cost and help more people get it. So while we might and we should continue to work on innovation on the vaccines, we should also look at how we can ensure that what's happened in the last 2 years doesn't get repeated as far as making the recipe for these vaccines available to more companies who have the capabilities to manufacture them more widely available.
Right. Thank you so much. And I think now we are exactly on time to take the questions from the audience. And there's a lot of really interesting stuff. The first one is coming your way, Dr. Pramesh, is that this is from Manjusha, who says that my parents are around age of 68 years, but they refuse to get vaccinated, even though they're highly educated. How do I convince them to get vaccination? And I think this is for most experts. All the experts here can answer it, but Dr. Pramesh, we can start with you first.
Yeah, that's a really easy question. It's tough. There's so much misinformation out, and while social media and the overwhelming amount of data and information that we have is hugely beneficial in various aspects. The flip side of that is that we've got these conspiracy theorists coming up with explanations, and I strongly believe that it's the human nature is such that it's easier to believe conspiracy theorists rather than believe the truth. The moon landing is a classic example, right? I mean, you have so many videos of those moon landings which have been touted to be fake, and people tend to believe that more than what actually happened. But the probable way to go about this is to present people with the facts as they exist, not overstate them. And I think I'll come back to a point I made earlier, that often the pro-vaccine folks have overstated the benefits of the vaccine to a point that people believe, or people were made to believe, that if you take the vaccine that you're immune from getting COVID. And that's far from the truth, right? And especially with the Omicron variant, it's even further from the truth. And when you find your claims being disproved so often, people tend to lose credibility in everything that you've said before. So rather than try and do that, I would strongly urge that regardless of the challenges involved in communicating the data, and this is pretty complex data, it's not easy data to convey to lay folks who are not well versed with statistics. But at the same time, I think so long as we stick to the data, we could go a little further. But I'd love to hear Bill's and Dr. Kang's opinions on this.
Right. I mean, yeah, just kind of staying on that, because there's another question that's similar to what was just kind of discussed. Is that it's a great segue also, is that the current discourse on vaccination and the measures that's been put up for COVID-19, do you think this will have a negative spillover effect on other kind of vaccination, especially the childhood vaccination, where we've seen after many years a great success, where people, the anti-vaccine sentiments have waned, but COVID-19 and the whole sort of questioning of vaccines, of COVID and the measures surrounding that, do you worry that it might sort of take away those gains that we have sort of got after several years? Dr. William, what's your view?
Yes, I very much worry about that. I do want to start by just adding my own view to what Pramesh was just saying, which was extremely smart. I think that if you're dealing with people in that situation, it is important to listen to them and understand their reasons. And you're not trying to, I think that if we try to sort of insist that the science tells them that they're wrong, then they are more likely to retreat into and become defensive. But listen to their reasons. They may have reasons which you can talk to about, and if at the very least you'll understand them better. And understanding others is something which is really important for all of us. When I speak about vaccination, I think that the language that I tend to use is that you are preparing your immune system. You're like training it. And that means that if and when you do encounter the virus, you're doing so with the best preparation possible, and everybody should encounter it as well prepared as they could be. So that's just my personal language for how I try to square that circle that we were just hearing about, because vaccines are incredibly good, but they are also not something which solves everything instantaneously. when it comes to the knock-on effects, indeed, and I can see that here in the United States, where vaccination or anti-vaccination has actually become a political wedge issue, akin to issues like guns or abortion. And a substantial part of the Republican base is now defining itself by whether or not it takes COVID vaccines. And it's a desperately unfortunate situation, because it would be incredibly sad if we ended up having more problems with infectious disease going forward, because a significant fraction are skeptical of vaccines, for instance, for measles, because you really need to keep up a very high level of coverage of immunity against measles in order to prevent outbreaks. I hope it won't happen. I'm not overwhelmingly confident that it won't happen.
Ma'am?
So I think Bill has it absolutely right. Listening to people and showing that you're willing to listen to them and not impose your views on them is absolutely critical. And we've seen that in the work that we've done in communities in India as well, that sometimes it's misinformation, sometimes it's something that you would have absolutely not predicted from everything that we know about misinformation. We have no clue where this comes from, how that framing is, but until we are willing to listen, we won't know what it is. The other thing I think is really important is not to be in a hurry. When you're talking to people, it may take, time, a lot of listening before they actually come to believe that you are really hearing them. And once that happens, then you can think about what is a credible source of information. Again, not imposing your views on them, but at least communicating what is known if they are willing to listen. And most people, if you're willing to make this a process instead of a one-off, are more willing to listen. And if you can find the right credible sources, I think you can build a communication strategy that is tailored to individuals and to communities that can make a difference. For example, I've spoken to a girl who was a dancer, and she worked with communities to think about what kinds of communication strategies have previously worked in to talk about vaccines. So it became more of a performance that then started the conversation that allowed for health officials to then have an inroad into that community to talk to them about vaccination. In India, in general, we have not had issues with childhood vaccination except for polio. There was a problem with the measles rubella program, but the stories and the narrative that we got was very similar to the one that had been used for polio. So we know a lot about why people choose not to get vaccinated. But there's also a lot that we don't know, and we won't learn about that unless we listen.
Right. Thank you so much. There is another question that's, I think, specifically directed perhaps to Dr. William, is that what about parents who have young children, about 2 years old, who are waiting for the COVID-19 vaccine for infants, sort of, get an approval. But in case if it doesn't get through, is there any vaccine recommendation that you would have for 6 months and up that can be like one more additional toolbox for children who have not yet been affected by COVID-19 but who are young and still do not have any protection? Any suggestions?
I think that, the first thing I would say is I don't think I can make any recommendations about vaccines which have not got emergency use authorization or otherwise have been passed. And I think that you do have to talk these things over with your pediatrician, because they will know both you and your child far better than I could. I will reiterate that the risks of COVID in that age group are very low. I would encourage people to get protection if and when such a vaccine does become available and is safe and effective. Then that's a different situation. But until then, I think that that's a situation where, unfortunately, people in that position are in something of a holding pattern. But again, your child is much, much, much less likely than than older unvaccinated people to suffer severe infection.
Got it. Thank you. I hope our audience got that answer. This is again another question on vaccine hesitancy, specifically in rural India, where this is vaccine hesitancy in rural India is not about politics, but more about religion and logistical availability of actual vaccines. What can be done and what can we think about it that the last number of people who live in the tribal areas and rural areas get vaccinated? What measures are needed? Dr. Pramesh, do you want to take that question?
You're asking me all the easy questions now. So it's again, as both Dr. Kang and Bill mentioned, a lot of communication that needs to go into that. But in general, what I've noticed in rural India, and I've traveled a bit with all precautions over the last few months, has been the fact that it's almost a denial of a fact that there is something like COVID. So if you go into the really rural part of India, there are all people walking around, no masks, no vaccinations, and it's almost as if it's life back to normal. And if you actually ask them, it does seem like there has not been a great deal of COVID in their communities. I don't know whether it has to do with the fact that they are far removed from crowded places, whether they spend the majority of their time in the outdoors as compared to people in urban areas. But it does seem that the overall penetration of COVID in rural India has been less than what it has been in urban India. So again, if it comes back to triaging how you were to give it, I'm not for a moment suggesting that you go out with the messaging that it's not important in rural India and it's important only in urban India. But I would be less concerned if someone in rural India, especially someone who was spending the majority of their time out in the outdoors, there's not much of contamination of these villages by people coming in from locations where there's a higher prevalence of COVID. I'd be less concerned about that than what's happening in crowded metropolitan cities in India.
Right. We have 3 minutes left, and I'm going to quickly take a couple of questions and a request to our panelists also just to kind of keep the responses really like crisp as we move on to the last of the 2 minutes. This is a question on, once we move from the pandemic to the endemic stage, what are the 3 specific definitive changes you would like to see in the public health administration? For example, do you think from the Indian context, accounting of excess deaths in mortality stats, or public health being shifted to the concurrent list of subjects? What are the 3 definitive changes you would like to see? I'll start with Dr. Gagandeep Kang, and then we'll move on to the others.
So changes I would like to see is the integrated disease surveillance program doing what it's supposed to be doing. And that, I think, it needs to be there all the time. And what has been happening is a lot of variability. That's number 1. Number 2, care for patients. Rational care for patients being taught in medical schools, being implemented. The kind of polypharmacy that we saw last time around, we still see is not needed. And the third is actually better education of our frontline staff and better empowerment for them to detect signals, because they're the ones that communities really trust.
Dr. William, 3 changes or interventions that you should come?
I love the surveillance one. I would extend that to being better data collection across multiple different things, including electronic health records, because there have been so many times when I have known exactly what I need to know to answer a question, but the data haven't been available. I would add to that perhaps a greater flexibility in terms of how we respond to threats. And while thinking for the next pandemic, I wish we had done this in advance, that we had set specific criteria and thresholds for when you would take action. Because if you're facing something that changes very quickly, you cannot spend time arguing over what you're going to do. You have to do something. And if it turns out that perhaps it was a little premature, well, you'll be darned if you do, but you'll be damned if you don't.
Dr. Pramesh.
I'd echo what both Dr. Kang and Bill said. Data, but I'll just add open, credible communication to go with the data to ensure that we don't send mixed messages. One of the problems that we had over the last couple of years, it's got better now, has been the fact that we've had very divergent messages coming in from people in important places. And that's something that we should really guard against. Agility with decisions, and I think this is something that stood us in good stead when we handled the first wave of the pandemic. We were literally thinking on our feet, changing decisions in hours more than days. And I think this kind of ability to make decisions on the fly is important. Dr. Kang mentioned this, but I'll emphasize this: the emphasis on evidence-based care. I think we completely lost it with the kind of treatment decisions that doctors were making when it came to treating people with cancer. And this goes from even decisions on admitting patients with COVID into hospitals, because we were admitting mild patients with COVID in hospitals, denying patients with moderate and severe COVID the possibility of a bed. And I think we saw this in stark detail when the Delta wave struck us last year. And finally, I think there needs to be a much better preparedness as far as healthcare systems are concerned. I mentioned this before, but I think even as it exists now, we are stretching the boundaries of healthcare preparedness. And unless we build in some redundancy into the system, we'll be in a similar spot with future pandemics as well.
Great. Thank you so much. I think this has been by far the most informative seminars, I think, of this year, because it's just starting off. But thank you so much to all our panelists for joining, and thank you for the audience for engaging throughout. We've overshot by 2 minutes, but I think it's worth it. Have a good evening, good day for people across the world. Thank you so much.